So welcome to the next in our series of discussions entitled The Power of Pivoting, Managing Through Crisis, a discussion of the HSS response to the COVID-19 pandemic. So today we're going to talk about telehealth and have invited two of the leaders in the telehealth effort at special surgery to discuss these efforts today. The first is Dr. Harvinder Sandhu, who is a professor of surgery at Weill Cornell Medicine and an orthopedic spine surgeon, in fact, co-chief of the HSS spine service. In addition to his active practice, he is engaged in research and the development of a number of devices that pertain to spine surgery. And then we have JeMe Cioppa-Mosca, the Senior Vice President at HSS and Director of our Rehabilitation Services, a title that really only scratches the surface of the range of her responsibilities here, which is vast, including over 20 sites pertaining to rehabilitation and over 200 independent practices. Anyways, I can tell you from personal experience, if you want to get something done at HSS, you just ask JeMe to do it. So welcome, Vin and JeMe. Maybe to begin, I could just simply say that although we knew telehealth was coming, the coronavirus has certainly served as an extreme accelerant on that practice. And in fact, JeMe just told me that in the last month, we have done, the physicians and the therapists collectively, over 13,000 telehealth visits, which is essentially up from zero prior to the COVID crisis. So welcome to both of you. And maybe, Vin, you can begin by telling us a little bit about this effort from the physician's perspective.
Sure, Ron. As you know, we sort of got into telehealth because we had to. This experience with the pandemic forced social distancing. We had to shut down our outpatient clinics and much of our surgical volume, but we still had to engage with our patients. We still had patients we had just treated or patients we were in the midst of treating, and we had to find a way to continue to interact with them. And we were, like most institutions, aware of telehealth, but what we did was just rapidly ramp that up. We had plans to bring telehealth to our institution years ago and had a rollout that was over a number of months, if not more than a year, and we had to do this within a matter of weeks. And so we rolled it out, and again, out of necessity. And in fact, what was interesting was that many of my colleagues, so I don't think ever imagined they would be using this kind of platform to talk to their patients, adopted it because they had to. And as it turned out, they really enjoyed it for a variety of reasons that we'll talk about. But what was amazing was that the adoption was quick on both the physician side and the patient side, and we were able to interact almost immediately. But we also learned a lot in the first number of, like anything, when you're in the middle of a crisis, oftentimes some of the great innovations happen during a crisis, and we innovated as well. We learned how to engage with our patients, how to examine them without touching them. That was a big endeavor. But we learned very quickly, and most importantly, we shared that information amongst each other. In fact, in the spine group, we've already submitted a paper for publication on how to properly do a physical examination utilizing telehealth. So, bottom line, we learned a lot very quickly, but we're very pleasantly surprised with how it all transpired.
So JeMe, how about from the physical therapist standpoint? Again, a relatively hands-on kind of activity, one that you have to lead people through, various physical maneuvers and so on to get a sense of their capacity or their incapacity. So how's that work?
Yeah, I think similar to Dr. Sandhu, Rehab had and Performance had a very similar experience. We were lucky enough that due to the CJR bundle, we had started HSS at Home about 18 months ago, where we were working with our arthroplasty physicians and the Medicare population. And it's just interesting, as a side note, we've not only have the physicians and the therapists enjoyed it, but we got a tremendous response from the patients as well, which I don't think we kind of thought that would happen. So we had started doing that post total hip and total knee patients. And as Dr. Sandhu said, that was going along. We had a trajectory of about a year to 18 months to expand it and roll it out. And in about 2 weeks, brought 133 clinicians up and live on telehealth for the exact same reasons. We had referrals from physicians who they had just done surgery and their patients needed therapy. We were in the midst of treating people, and have also discovered a lot of lessons learned. And what can you treat at home really well? What perhaps can't you treat at home really well? And I think that's important as we move into the return to new normal, to understand what works and doesn't work so that telehealth becomes embedded into the fabric and tapestry of what we are doing here at HSS and becomes part of the episode of care. So we're working on that now, Ron, in terms of trying to balance where does it make the most sense for telehealth to be part of our episode of care.
So, I think of the physical therapy department, maybe not so much here, but in a lot of places where there is a fairly large component of elderly patients. Now, do you have any difficulty in their adoption of this technology? Because I've had a little problem in my practice with respect to that.
Overall, I was surprised at how quickly people adopted it right from the get-go. I think the pandemic, there wasn't an option, so I think maybe some people who would have been a little bit more gun-shy wouldn't have been. I mean, clearly, if you don't have an iPad or a phone or a computer, that is definitely a stumbling block because that doesn't work. But I think what we've learned, and I don't know, Dr. Sandhu, if you want to comment, the amount of work you do up front and the amount of work that our team from the access side did up front to make the patients comfortable and help coach them through so that when the clinician actually gets on the visit, they feel much more ready to go. And I think some of the lessons learned now is how can we streamline the process so it's even easier. It's a tad cumbersome, not terribly cumbersome, but there's some apps they need to download, and in an ideal world, I guess they would push a button and they would be in telehealth. So what do you think?
Yeah, I mean, I think you're absolutely right. The more you do on the front end in preparing these patients for that interaction, I think the better that they do. What's interesting that I hear from my staff is that patients who come from large extended families tend to adopt it much more quickly. And at first we didn't understand why, and then we realized many of them have used FaceTime to communicate with their family. Many have used Zoom. So all generations have been accustomed to this idea of communicating visually and virtually. And when explained to them that, well, you're going to see your doctor in the same way, kind of makes sense to them. And they just need to know which particular apps to activate and what buttons to press. But we are, at the same time, we're also trying to make the interaction like a true interaction as you would do in the clinic. So it's also important that they continue to fill out the digital forms that they customarily did in clinic. We don't want to skip any of those steps. The only thing we're not doing is that hands-on interaction, but so much of a clinic visit doesn't involve the hands-on part. It's everything else. We make sure that all of that is incorporated into it.
So Vin, you made a comment there that's somewhat interesting, and maybe both of you could comment on this as well, and that is the role of the family. Now, they have some role perhaps in the facilitation of the technology, but they're also actually able to attend the sessions now, which might be somewhat different than in a physician's office or at a rehabilitation or physical therapy department. So how has that been as an experience?
I think, Ron, to start with, I think we have always underestimated the anxiety and stress that patients go through when they actually physically come into a doctor's office. They have to travel in, sometimes at a distance. They have to park their car and pay for the parking and find their way to the office, and it's somewhat chaotic to them, and there's a lot of stress. And then once they get to the office, there's a waiting room, and they're moving from room to room, and there are a lot of distractions. It's stressful. And then you have the interaction, and oftentimes patients leave and say, gosh, I wish I remembered to ask this question or this question or this question. One of the first things I experienced with telehealth is I wasn't getting those comments. they were asking all the questions that were on their mind. And I think part of that is that they're talking from the comfort of their own home. They know exactly where the visit is going to be. It's going to be in their living room or their office. They don't have to find the place. There aren't other distractions. There aren't a bunch of people not only distracting them, but distracting the doctor. We forget when we're in the clinic, oh, there's a phone call. Okay, let me walk out and then come back in 5 minutes later and the patient now has forgotten what they were talking about. That doesn't happen. It's a much more focused interaction. But the best part is when, in terms of the family interaction, there are parts of that interview that I do want to see the patient more thoroughly. I want to watch them do things. I want to watch them walk. I may have them walk on their toes or their heels or bend over or carry something, and I want to test their motor strength. Where the family member comes in is they can actually hold the camera or the device that's recording, and that's really great because first of all, they obviously have care for their family member. They want to do it exactly the right way. They want to capture the most important information. And they're the ones weighing in, doctor, did I do it right? Can we do it again? I just want to make sure you see everything. And I think that interaction just improves the whole relationship with the patient and the family.
Yeah. So I would totally agree. It is amazing how distracted clinicians get in the clinic, and I think patients feel they're getting your undivided attention, which they are. And the other thing is the involvement of family, which has been wonderful, and people can ask questions because they're there. I think the patient thinks they have a little more control because they're in their own home. And from a home exercise program, what we've noticed is there's a lot of people who in the clinic can do return demonstration, and now when they're at home and the therapist or the performance specialist is watching them, we've realized a lot of people are not doing their exercises correctly. So watching them in their own environment trying to do exercises, or if it's a mom or a caregiver working with a child with torticollis, you can coach them in their home environment. And the other thing we've learned to do is be incredibly creative because people have had to stay home. So how do you use their home and the things they have in their house as exercise tools? So I think that's been fascinating, and I think it's going to be critical in our return to new normal and should be part of like the home exercise program experience, that one of the visits specifically is scheduled so you're watching the caregiver or the patient in their home doing what they're supposed to be doing.
So, JeMe, something that's perhaps more relevant to the physical therapist, what about safety considerations?
Yeah. So I think you have to be careful. If many of the patients were instructed if they're not comfortable standing, that they should be sitting. So this gets into the prep of the pre-visit. And as Dr. Sandhu was saying, if they have family members around, that's important because where the camera is and having another set of hands sometimes is helpful. And this gets back to lessons learned, especially people perhaps with vestibular issues or severe balance issues. Telehealth isn't for them. There are people who absolutely need to be in the clinic because you wouldn't want to be doing something with them without the ability to actually guard them. And I think you have to be careful because we don't want to put the family member at risk either. So I think it gets back to these lessons learned on there's so much we can do from telehealth, but there's a portion that you cannot replace in-person, hands-on care.
Okay, so what about payment considerations now? And I'm not just limiting that to the practitioner here, but what about payments and insurance support for this activity for the patients?
Just coincidentally, back in February, I was at a conference out on the West Coast, and I was asked to discuss the use of technology and how we were going to adopt technology in our field and interaction. And obviously the hot topic was telehealth. And this is all before we knew how the pandemic was going to affect us. And one of the questions that came up was the cost analysis. So I did a little analysis, and we're in a unique place here in New York in that many things cost more than they would in other places. But I calculated for the average spine surgeon who is seeing patients in a clinic, what were the costs accrued to the family in having to come in and for that in-person visit. And that would include driving the car, the tolls, the gas, the parking, but also the intangible costs, for example, the time out of work, or the time out of work for a family member who has to bring you in for that visit. And I calculated in an average clinic day, that cost is about $3,000 that is expensed by these patients having to come in to see the doctor. That's not covered by insurance in any fashion, and it's not funds that are going to the provider. It's just an expense because of the system. So I think in a way, yes, there's a cost to telehealth, but I think by and large, I've not had one patient yet who complained that they had to pay this copay or this cost in comparison to what they were paying in coming to see the doctor in person. In fact, I think there's a lot of cost efficiencies in the whole system. What made it easier, of course, to adopt telehealth was that the insurance companies came on board, began to develop fee schedules for these visits. They understood that that was the only way a lot of patients were going to get care. But I think that was very critical. And I think it will be a legacy of this whole event, that we are going to have a really nice way of interacting with patients that's cost effective, that we'll just continue to use in our practices.
Yeah, I would agree. For physical therapy in particular, telehealth was not covered prior to the pandemic, and the insurance companies and payers did a wonderful job relaxing some of those restrictions and putting reimbursement back on the table for that. I think the algorithm for what the reimbursement will be moving forward after the pandemic is still a little unclear. But clearly, I think people have demonstrated in all walks of life that it is critical for safety and for patient care, and how that will transcend is to be determined, but hopefully will be something that continues moving forward and will probably be the legacy of the pandemic. I agree.
So Vin, one point that is perhaps most relevant to you, and that has to do with the capacity to review images with patients. Can you tell us a little bit about that? Is this a facilitator of that? Is it an impediment to that? Patients are very interested in what their x-rays look like, particularly after the kind of work you do.
Ron, that was one of the things I never anticipated getting into this. When I learned how we could review images with a patient in terms of using screen sharing and so on, I realized something that was a big advantage using the technology. Think about how we review images currently with patients in person. There's a computer, a limited screen, and you're standing there with a mouse and you're trying to point out things. The patient is usually looking over your shoulder and is not fully looking at what you're looking at because you're in the way. You're looking for yourself to find the right images and so on. When you're using a screen sharing system, you're doing what you normally do, but the patient is seeing through your eyes exactly what you're doing and not looking over your shoulder. It's really fascinating because for decades I've been going over films with patients. I rarely have patients saying, "Oh, that's really fascinating," but when I've been using telehealth, they get very excited. And oftentimes you'll hear them call a family member who isn't right there, "Hey, come and look at this. You can see the herniated disc. You can see where it's pushing against the nerve." And I realized there's so much more focus and clarity using this platform as opposed to what we were doing before.
Is there any analog for that in PT and in demonstrating things?
Not exactly the same, but I think the concept of being super focused and having them engaged and in their own home has been something that we didn't really anticipate at the level that we have for all the patients. I mean, we have started doing our normal patient satisfaction surveys like we do for our in and out patients here for the telehealth population at HSS, and the numbers are through the roof, like 4.97 out of 5. I mean, higher than pretty much any of our outpatient scores.
Really? Interesting.
Yeah.
So in bringing this to a conclusion, and I think you've both referenced it a little bit already, if we fast forward to a year from now, where is telehealth going to fit into our range of capacity to interact with patients?
Yeah, Ron, as I said, I think this is going to be a legacy of this whole event for us. We're going to continue to use it, but I think we're going to be a little more innovative in how we use it. We've not been using it in the typical circumstance where we have people back in the workforce, people busy. Right now, a lot of people have extra time. It's been easier to interact. But I imagine a day when everyone's, our regular work life is back to where it was. People have limited times during the day. It's hard for them to take time off during the day to see the doctor. We're going to start to use this technology during hours that are convenient for the patient. Evening hours, Saturday morning, maybe Sunday morning, doing a few visits. The beauty of it is you don't really need all of the resources you normally need for inpatient visit. You don't need all the staffing, you don't need the rooms, you don't need all of that. You can do it from the comfort of your house as a provider, and the patient is comfortable in their house, and you may be comfortable doing this in off hours, which is tremendously convenient to our patients. And as we begin to learn these things, I think we're going to have greater adoption of the whole technology.
Yeah, I would totally agree. I think this next phase, especially as the curve is declining, the next 6 to 10 months, it's going to be critical for us to be able to continue to do telehealth for patient safety, social distancing. The inpatient clinics, we can't have the number of patients and providers in a certain area if we're going to comply, which of course we are. So I think it's going to have an impact on the way we deliver care, especially between now and January. And then moving forward, especially at a place like Hospital for Special Surgery, where patients travel typically within a 75 to 90 mile radius, they probably don't need to come back for a routine post-op check if all is going well. And there are things that we can do to make their life easier, and I think it's more efficient, and in the long run, we'll have cost savings for the entire system.
Good. Well, JeMe, Vin, thanks so much for doing this. It's a fascinating development, perhaps unanticipated one from the coronavirus epidemic.
Thank you, Ron.
Thanks, Ron.
Yeah.